morning here at the World Health Summit 2025 in this early hour. I hope you all had your caffeine or tein shot. And I welcome you to what I believe will be a critical and awakening conversation about one of the most overlooked opportunities in strengthening global health. My name is Ludmilla Schlageter. I'm the head of the DSW office here in Berlin and also the head of the German advocacy. For decades, medical research has operated on an androcentric model, designed by men, primarily tested on men, and applied universally. The consequences are profound. Women experience different symptoms for the same disease, respond differently to medication, and face conditions that are understudied or ignored entirely. In my case, for example, when I had a migraine, I went to the doctor and the first question was, are you stressed? Do you have a different life? What's happening with you? Are you sure? How is your hormonal status? My friend Ollie goes to the doctor with a migraine, Oliver, and he gets an MR to check is his spinal cord okay? So there we go. For too long, we can see medical research has been built around a male default, overlooking the biological and social dimensions that shape women's health outcomes. The results have been persistent inequalities across conditions that affect women differently or uniquely, and that is true for the female patient. It is true for women's sexual and reproductive health, and among those, most overlooked, the lactating and pregnant women, who remain excluded from clinical research at this moment in time, mostly. In global health today, and I'm sure you all know the figures, I'll still do them again. 70% of health workforce are female. More than half of world's population is female. Yet, they still hold only 25% of leadership roles in health systems, and 37% only are principal investigators in clinical trials. This imbalance continues to shape whose health is prioritized and how innovation evolves. I'll just do a last introductory remark because I'm German and I represent a German NGO. So here in Germany, both Health Minister Nina Wacken and Research Minister Baer has signaled a stronger national focus on women's health, embedding sex and gender perspective in health research, improving data quality, prevention and strengthening care across all life stages, including sexual and reproductive health and rights, and hopefully also supporting pregnancy and lactation. This isn't just a matter of equity, though it's certainly also that. It's also, as we all know, the McKinsey report, it's also a 1 trillion opportunity in global economy annually. So $1 invested in women's health is a return on investment of $3. And our discussion today will explore how research and innovation can drive that transformation through inclusive data, smarter investment, and coordinated action across science, policy, and industry. Today, we're also exploring how this transformation can be driven for everyone, everywhere. And we have this exceptional panel representing the full ecosystem needed for the change. So welcome to my panel. And I will quickly introduce you in alphabetical order, so it's not gender bias. Oliver, Oliver Appelhans is the head of the specialty business division of Daiichi Sankyo, Europe, where he heads the cardiovascular business across the region. He previously served as vice president of commercial operations and affiliate partner management, and also as general manager of Daiichi Sankyo, Germany. With a diploma in chemistry, Oliver began his career in AstraZeneca, where he gained valuable experience in different therapy areas. Over the years, he has taken numerous leadership and executive development courses, further enhancing his expertise in pharmaceutical industry, and he has actually launched the program for cardiovascular medicine across Europe, focusing on patient engagement and addressing unmet medical needs. He collaborates also with patient organizations, healthcare bodies, and payers, which is very important in Germany, recognizing the need for a nuanced approach for cardiovascular care. Guided by the motto, "We care for every heartbeat," Oliver leads his organization to continuously deliver value and innovative solutions. His emphasis on collaboration, co-creation, and transparent relationship ensures that Daiichi Sankyo Europe remains at the forefront of addressing the evolving needs of the healthcare ecosystem. Welcome, Oliver. Pascal. Hi, we met so many times already this week, so I'm very happy to have you on the panel. Dr. Pascal Atolai, she is the director of the WHO's Department of Sexual and Reproductive, Maternal, Child, Adolescence, Health and Aging, and leads the UN Special Program for Human Reproduction, HRP. A global respected nurse, midwife, and public health expert, she brings over 30 years of academic and UN leadership advancing women's health, SRHR, equity, and human rights. Her work bridges science, policy, and implementation, supporting countries and partners to deliver inclusive, evidence-based health systems that uphold rights and improve outcomes across the life course. Welcome, Pascal. Dr. Sarah Korsowicz is a Lancet Commissioner and Global Health Policy Strategist with extensive experience working across multilateral institutions, governments, and the private sector to strengthen health governance systems and diplomacy. She serves on the board of directors of Women in Global Health and also opened the chapter in Sweden. She held roles with UNFPA, the Royal Swedish Academy of Science, contributed to infectious disease prevention at the European Centre of Disease Prevention and Control, the ECDC, and led regulatory affairs for Novartis and Sanofi. Her consultancy portfolio, amongst others, includes the World Bank and the Swedish International Development Corporation. Currently a postdoctoral fellow at the Stockholm University. She has published widely on gender equality, migration and health, and infectious disease prevention. A Fulbright scholar, she holds a PhD in medical science, very impressive, from the Karolinska Institute, Sweden, an MSc in global health policy from the London School of Hygiene and Tropical Medicine, and attended the Master of Public Health program at Johns Hopkins Bloomberg School of Public Health as a visiting research scientist at the Center for Public Health and Human Rights. Welcome, Sarah. So impressive. I didn't want to leave out anything, finally. We also have Frank Neumann with us, a coordinator for the foreign policy dimension of global health at the German Federal Foreign Office. He's a career diplomat, and he previously served as a deputy head at the German embassy in Kuwait, and earlier postings included postings at as a deputy head of the German embassy of the United Arab Emirates, and also Sudan. Thanks so much for being here with us, Frank. Welcome. So it's a very impressive panel we have here, and also very diverse. So I really want to start digging a little bit deeper into what is our topic today, innovating to close the gender health gap. And I would like to start with Pascal. The WHO is uniquely positioned to see the global landscape of women's health research. From your vantage point, Pascal, what are the most significant gaps we are facing when it comes to understanding sex and gender differences in health? And what does it take institutionally to systematically integrate sex and gender considerations in global health? It should work. It should work. Just
great.
Yes.
Can everyone hear me? Okay, great. First of all, just to say, it's incredibly frustrating that we're still having this conversation. Yes. And it really does worry me. And I'm almost at the end of my career. It will be so nice if I can say by the time I finish in a few years' time that this won't be an issue. And coming from the WHO perspective and the multilateral perspective, one would hope that we've got equity and all of these embedded within our values. I think we are in a particularly good time now because we have a Director General who is very supportive of these issues, but the work is constantly making sure that it is protected for the next person, and it's just not okay. Just a very quick anecdote before I start. We recently, since I started in WHO, we had a refresh of the emergency packs that for our humanitarian staff. We actually, the female staff, had to rally and fight to have menstrual products put in. It wasn't a problem to have condoms in there. But to get menstrual products put in as standard, we had to make a case. We actually had to rally and threaten to go and have a demonstration to have it considered. We shouldn't have to do this. So we are at a time, at least, where these issues are coming to the fore, but we need to move it forward. I think from our perspective, one of the big gaps is that even as we begin to talk about it now, we still treat womanhood as a risk factor rather than as normal. And I think, again, as the agenda moves forward, this is one of the things that we really have to address. We're not a minority group. We're not talking about diseases. We're just talking about 50-some% of the population that we need to move forward with. So women's bodies have been rendered exceptional, and what they should be is foundational. It's just who we are. So WHO and the UN department, the UN entity that I cover, the HRP that we spoke about, and HRP had to be created very specifically so that we could continue to do this work within the multilateral system, because some member states are less comfortable about talking about women and sex because we don't have sex as human beings. And so there is a separate entity, HRP, which is able, with the support of a number of member states, to be able to continue to drive the science in sexual health generally, women's issues in particular. So we're working to correct the imbalance of both global norms and practical mechanisms to advance sex disaggregated data requirements, specifically gender mainstreaming across all of WHO outputs. This is done through our gender department. And more recently, the SAGA guidelines to ensure that published data, all of our work, reflects women's realities. So this year, we've established a task force on the inclusion of pregnant and lactating women in clinical research. And this was, again, the sorts of gaps that we're talking about. We have, what we're really looking to do is establish and develop guidance for ethical inclusion, because that has always been the problem as well. First of all, it was just women, and now it's pregnant and lactating women. And the concern has been that ethically it's not okay. Now, even then, all of the discussion is about the teratogenicity. So the concern is always for the fetus rather than for the woman in and of itself. And we've done the research, and we know that it is possible, and the pregnant and lactating women will consent to be a part of clinical trials. So we're looking to establish a list of priority medicines, because we know that at least 70% of pregnant women do need to take something, in spite of the fact that we've been told we can't even take paracetamol when we're pregnant. So this is a hope that by 2030, all women will be systematically included in research trials, and that health workers will make informed and evidence-based clinical decisions. Again, part of the problem is that when a pregnant woman has to take medication during pregnancy, she is taking on the risk. We did a review, over 85% of medical the information booklet in medicines say that you're not allowed to take them during pregnancy or you take them at your own risk. And it is because pregnant women are supposed to be vulnerable, but they are also vulnerable to the conditions for which they need support. So without clearing that particular gap, we're going to continue to be stuck. The R&D needs to be dealt with as well, because we know that 40%, the blood volume increases by 40% during pregnancy. And therefore, what we know now is not enough. We don't have enough clinical information to understand. So we have to invest in this. And this is, for me, the priority before I retire from WHO, that we will be able to get through ensuring that the guidelines at least are available to overcome the hurdle of preventing research on pregnant and lactating women.
Thank you. Very, very important topics, and just want to move over to Frank now, who is representing the Foreign Ministry. You just talk. Some people will be wondering why we have the Foreign Ministry, but we have a very stringent government currently on pharmaceuticals, sexual and reproductive health and rights being part of the economic development, female and women health being part of the Ministry of Health and Research and Development. And so we would like to hear from Frank, what is the role in strengthening global health and also women's health of the Foreign Ministry in this context?
Thank you, Ludi. Is this audible?
Yes.
Thanks for having us. It's a first for us too. We are not frequent guests at the World Health Summit, but we hope that in future years this will become a normalcy. Why we appreciate the opportunity is, I was just thinking that listening to people like you, the practitioners, I rarely ever saw someone get down to brass tacks so quickly, and I found myself totally engulfed just listening. It's very important. I'm reminding myself why we're sitting here in this circle. We are supposed to outline policies, draft them together. How can we do that without practitioners, like people who know what they're talking about in the field? These two sides of the medal need to be brought together for maximum efficiency. A second observation, I can't help noticing, if I look at the number of men in the room, I almost feel like an exclusive species. So that also needs to change. This is a topic that is not a topic for women, it's a topic for all of us. You said it rightly, Ludi, in the beginning. So why do we need diplomacy? What can diplomacy do to advance these causes? First of all, we all believe in the same thing. Governments are not black boxes anymore. We are held accountable, we answer to people, we answer to public questions. And it should be very normal for us to appear at these panels and let you know and feel that we're working for the same cause. And we can't do this alone, we can't do this without you. We need to bring all the sides together and all the stakeholders and listen to them very carefully. I'm saying that because policy is not a far-removed subject. It is not something that you can't touch or feel. Policy is decisions taken by living people. We're all fathers, we're all mothers in our desks and offices. And we want to act in the interest of all of us here in the room. For that, we need to touch base with reality. So otherwise, you will end up designing far-removed policies that have little to do with realities. You just reminded us what the reality can look like. It's grim. On some fronts, we're even digressing. It's not that we see progress. And I want to outline in a very few words what diplomacy can do. When we talk about global health diplomacy, I'm sure we all have something in mind. We all see something. There is a tangible idea of what that might be. And yet, if I asked you to write it down on paper, you'd probably all write something slightly different. And that's because the terms are a little fuzzy in that subject. They flow from previous experiences with global health governance, for instance, when countries engaged into bilateral contacts across the borders, because the simplicity of things is diseases do not stop at borders. And national politics or policies alone will never solve the problem. So this is the thinking that, thank God, took root with all of us, and we understood the necessity of effective multilateralism. And that is something that Germany is, the government is very much committed to. Even at times when some countries have shoestring budgets, we understand the necessity not to let up in our efforts, because the progress that we've been making in some of the areas, if you take vaccination campaigns, for instance, is very, very quickly eroded unless it is followed up by renewed action, so that progress of the past is not just wiped out. It's very important to have industry on board, because all this is also a matter of capacities and production and so on and so forth. What can diplomacy do? Diplomacy, you can look at it in an academic way and go back to the founding fathers of WHO, and you will find very smart words and ideas in the founding statutes of WHO, which in the end, every country signs up, but has a slightly different idea how that should be put in practice on a national scale. And then you find people based on the same statutes expressing different ideas how this should translate into practice. You need people who come to an equilibrium in all of this, who strike a healthy balance to come to a happy medium with which we can all live. That's what diplomats do. We translate the policies and the treaties we signed up to into practical realities. We are aligning policies. We want to make sure that we're not losing efficiency in the process because everyone else is working for something slightly different in the process. So you could look at the legal basis, the normative framework, which of course for diplomats is like a guiding star. It's the polar star up there in the sky. You have a legal framework, but as we all know, implementation and practice sometimes looks very different. We need to make sure that countries actually do what they signed up to. So we find ourselves sitting in negotiations. We find ourselves working on language in resolutions, centered around, first of all, the United Nations system, because that's where most of the norm setting took place, but also in the daily doings of other stakeholders. Diplomacy today is much more than it used to be 20 years ago in health business, because health is such an all-encompassing subject. It spreads out. Not only does it not stop at borders, but it also has so many determinants in other sectors, is a variable in itself, and touches on so many other political fields that you cannot ignore to look at them too. In the end, it becomes a highly complex business. You can look at it like a layer cake. You have international regulations and norms, you have regional regulations and norms, and obviously institutions. You have the national laws and norms, and you have the local level. And the intersect of it all is where we're moving along with health diplomacy, trying to ensure that we're all working for the same outcome, trying to ensure that norms are not being eroded like we're seeing today in some areas, trying to ensure that basic human rights are not infringed upon, not violated, making sure that practically we live what we signed up to. Health is enshrined in the SDGs, it's enshrined in national laws, it's enshrined in international law. What we must not allow to happen is that we move back from that. And I'm sure especially the subject that you're an expert in is a very good case, talk about pushback. The pushback, that we need to be very vigilant and watchful, and here diplomacy can play a very important role. And I'm coming to an end with this initial statement. We also play an important role in international negotiations, just to mention the pandemic agreement that we are still in the process of negotiating in Geneva. And then obviously there is the annual meetings of the United Nations, all its special organizations. Germany, as you know full well, is a champion of multilateralism. We stand by this, and we will take this forward also in times of tight budgets. We will be a reliable partner on the front of women's rights, because we believe they are an essential element, not only of our human rights codex, but also of our global health policy as such. And we as a government work very closely together. When I say this, I'm also saying this mentally for colleagues in the Ministry of Economic Development and Cooperation, colleagues at the Ministry of Health, naturally, colleagues in the Ministry of Research and Technology and Space. So in short, global health diplomacy is more needed than ever. It's a growth industry, and we should take it very seriously because countries like Germany, especially since we are one of the largest funders of the system, have a lot to lose if we're not using the opportunities that spring from it. And that's why we will continue on this course and be a reliable partner, like I said, to all of the stakeholders. And we will listen very closely, and that's why I'm so glad to be here today.
Thanks so much. Thanks so much, Frank. Also for pointing out the gender gap discussions, the gender pushback discussions, the gender gap and the gender pushback discussions. A particularly important role that the policymakers have and the contract negotiators, because if you change the word from parental leave to maternal leave, for example, already you put the pressure again back on women and also women's health. So we see quite a lot of that wording, so we're very thankful that you're looking into that on a regular basis. Also, the World Health Assembly topics are of importance here, and while we see that women's health is growing, we also see how the pushback is coming towards us. So we heard from the policymakers. Let's turn to industry representatives on the panel. So hello, Oliver, again. You lead the cardiovascular innovation across Europe, an area where we know sex differences are particularly stark. Women often present with different symptoms and respond differently to treatment. Yet, historically, women have been underrepresented in cardiovascular research and medication treatments. What role can industry play to advance women's health, and what role can it play to have a better account for sex and gender differences in driving medical innovation?
Thank you very much for the question. So we at Daiichi Sankyo believe that improving and addressing women's health is not just a matter of equity. Improving health equity is essential to fulfill our purpose, to contribute to the enrichment of quality of life around the world. And we do this by developing innovative pharmaceuticals that address diverse medical needs. We all know cardiovascular disease is still the leading cause of death, including women. We also know that cardiovascular diseases equate to almost 1/3 of deaths all over the world. And we also know that cardiovascular diseases are still mainly perceived a male disease. And this is despite all activities that we do with regards to all prevention campaigns. The burden of cardiovascular diseases has plateaued. So in some countries, it's even going down. It's going back, if you like to. And we at Daiichi Sankyo, we are fully aware of these facts, and it influences all our activities with regards to clinical trials, studies, medical engagement, medical education, and also interaction with different stakeholders in the healthcare systems, such as policymakers, HCPs we already named, but also with regards to payers that are important, because by the end of the day, there's also someone that has to support and finance this entire thing. And how do we do this? So I would love to give you 3 different examples how we try to close the gender gap. And it all starts with awareness. Yeah, I think that must be the starting point. And we also have to address the data disparities, because data play a significant role. We talk about evidence-based medicine that is based on data. So you have to have these in order also to create something like personalized care, if you want to. So in our latest research, we looked into 8,500 patients and asked them about gender equity. Do you think it's equal? Do you think there's a gap? And what we saw is that the more than 50% said they are completely not aware of gender disparities. And we all know the example of the heart attack that male feel in the left arm, feel in the chest, whereas women has the pain in the back. And this is still something people are not aware of. And what was a little bit more striking was the fact that 2/3 of the male patients, for example, they received specific advice how to reduce their cardiovascular risk, what to do. And on the other hand side, it was only 50% of female patients who received such an advice. So for us, it is important to address this, for example, when it comes to study design. You mentioned 50% of the world is female. I tend to agree. And on the other hand side, when we look there and look for the representation in clinical trials, especially in the cardiovascular area, it equates to around about 40%. So you already can really give a number to that gap if you like to. And when we look on our own belly at Daiichi Sankyo, so we had our latest studies such as Santorini, such as the CLEAR Outcomes trial, both working in the lipid lowering area. We ensured a 50% participation of female patients. Yeah, that worked. But we also learned that we have to make a little bit more effort in order to understand why are not so many women participating in our trials. What can we do in order to improve this? And we found out that the best way to do so is to also work with more female PIs, with female principal investigators, because they know best what women may like or what is needed in order to have more female patients in the studies. And that brings me also to the next point, and you already gave some numbers, and I'm looking on cardiology and what we see there in the cardio universe, if you like to, that only 20% are female cardiologists, only 10% are in a leadership position. On the other hand side, 75% report about discrimination, report about harassment, and as a consequence out of this, there's a huge number of female cardiologists that also suffer from burnout by the end of the day. So what we did, for example, when we went in the lipid lowering field just recently, we always need advice from HCP. What is the burden of disease to understand better the patient needs? So we founded an European, pan-European advisory board, and we took care that we have at least 45% participation of female key opinion leader, because that is really important when we address a disease that is commonly spread around the world, based on elevated LDL-C levels, and what we have to do is reduce the cardiovascular risk. So we also have to discuss this with female opinion leaders, otherwise we won't reach the female patients, which is important to do so in order to fulfill our purpose. What we also do is we partner with an organization such as Women as One. That's a non-profit organization, a non-governmental organization that addresses and promotes gender equity, just to give you a couple of examples. Thank you.
Thanks so much, Oliver. Sarah, as someone on the panel who has worked in industry and in regulation and in policy, I just wanted to ask you, from multilateral institutions to government agencies, what do you think do we need? What is accelerating women's health? What is the most promising systematic integration of sex and gender into research, innovation, and then translating it into real life?
Good morning, everyone, and thank you for the invitation. Thank you for everyone that came this morning, especially the rare men in the room for being so courageous to show up here, and everything is being recorded, by the way. Happy to be here with this panel and to reflect a little bit also on their perceptions. I hope you all received the notes from yesterday, from World Health Summit notes from day 2. It says health is political. Health is political, and innovation is also political. And currently we're living in a rather fractured world when it comes to geopolitics, and innovation truly reflects that. I won't be as pessimistic, but I will say that we are in a place of paradox. So as we've heard, we have a lot of advancement when it comes to health diplomacy. WHO is doing quite a lot of job. The industry is here as well. We've heard a lot of research and development investments. We have more than 120 national health information systems that have sex disaggregated data. There's a lot being done from research perspective, because that is what I need to talk about as a researcher as well. We have the Lancet Commission on Women and Health. There has been a BMJ series just published on women, innovation, and health. So women's health is not being seen that much as a niche anymore, but it becomes really, prominent topic. But there are things that remain stubbornly unequal still, and we have heard a bit about that. It's about leadership, it's about investment, and it's about putting evidence into practice. And to be fair, we have brought ourselves here. We're trying to close the gender health gap with innovation, of course, as one of the tools. But as Oliver said, many of these things are because women were not in the decision-making spaces, women were not present in data, and women are not still in those rooms leading the efforts. And we're trying to close everything by denying that there was a governance gap, there was a gender gap, there was an equality gap, and there's a trust gap. So what we also need to reflect on is that, as I said, health is political. There are geopolitical forces that cannot really, help innovation. And when women's health is being sidelined, it's when it's not being seen as strategic, it becomes negotiable. So when you have intellectual property, when you have reference prices, when you have disruptive supply chains, that is when innovation needs to choose. Where do you invest? And women's health and closing the gender health gap, unfortunately, is not a priority. So it is the uncomfortable truth we need to change, and we do need to change it with policies and strategies that we need to bring together in the discussions. So what we usually demand in research, for example, and from funding agencies and from policies is the way that we create, we collect, and we interpret data for everyone else to be able to use it. So the demands are, for example, on the funding agencies that they do have sex and gender as part of their funding priorities. And, if you don't have that, you don't get a project for research. We demand government agencies to also implement policies that have sex and gender disaggregated data as part of their efforts. We also tend to demand tying regulatory approvals into market entry, as well as listening to different civil society organizations that are closest to living experiences of women and women's health into the discussions about, where the innovation needs to go next. Which brings me to my last point. We oftentimes tend to look at women as a monolith, one woman, and what is applicable there is universal. It is applicable to a woman in Stockholm, and it's applicable to a woman elsewhere. And that's not the truth, because if you innovate like that, your innovation can go as far. And all of your efforts that you invested in that innovation will not be applicable to everyone. And that really disrupts equity. Equity is not always in the discussion. So where the policy and strategies need to go is really to think as sex and gender as a systemic feature, as something that is smart, something that is not just a paragraph that you tick, but something that is really a smart and equitable investment. And this is where I'll stop. Thank you.
Thank you, Sarah. Pascal, you look like you would like to add on something.
Always.
Would you want to comment on any of what Sarah said and combine it maybe with sexual and reproductive health, one of your dear topics?
Absolutely.
Oh,
Thank you. I think I just want to extend a little bit when we talk about, R&D, the research bit of it, that this is inherently political. And I think we underutilize the political sciences, economic sciences, social sciences as communications, all of it, that understanding that these are all also incredibly well-researched areas and provide analyses that we don't use particularly well. So and I think you raised as well, both of you have raised the issues of the pushback. It's going to be really difficult for us to advance a lot of this work in the current geopolitical environment. It's very clear for us in WHO, at least we're no longer engaging, and so we don't have to worry so much about the new swear words of diversity, equity, and so on. And we can just soldier on. As I say, we've got very strong leadership in these issues, and we also have on the HRP side of things, we have that protection. But I do think that that is a bit that part of research and how we do the work, that evidence, the economic, social, political evidence, we need to bring in a bit more. And privilege much more than we do. I do want to raise as well the issue of in terms of the geopolitics, and sexual and reproductive health. This concern about the colonial nature of the issues that we talk about. Again, one of the things that we probably need a fair bit of time to go into that, but it is I think that is an excuse that we use, and we need to go beyond it and recognize that bottom line, this is stuff that is important for 50+% of the population, regardless of where you're born, which part of the geography you're born in, and I want to use this to make an appeal as well. That our colleagues from the global north not shy away from pushing and supporting these issues, because if the leadership is not there, these issues will go silent. We cannot afford anybody who believes that this is an important agenda to shy away from it. If it's important, please stand up for it in the politics, stand up against all of the pushback for it. We have to keep pushing on. It's insidious. The resistance to us being able to do this is insidious in all sorts of ways. I had a meeting with a number of women innovators, and they had talked about even being able to obtain supplies online, because you now have algorithms in terms of AI that will block the use of gender or the use of sex, or so even being able to work online, the internet space is not supportive of being able to move women's health innovation issues forward, because you can't, there is always a stop. There's always, without sounding conspiratorial, there's always something that stops it. AI in terms of innovations, obviously, there's a lot that we can do. Sometimes I think we overplay the risks. I think we need to be aware of them, but there's enormous, enormous potential for moving AI, technology, all of that forward, particularly for sexual and reproductive health, particularly in the self-care interventions area because of the issues of privacy and so on. Amazing innovations just over the last 5 years. Self-care for whether it's diagnostics with cervical cancer and so on, all the way through to management, self-care for medical abortion, all of that. There is huge potential, and again, just understanding it and making sure that we're hearing what women need. But also recognizing what the risks are broadly in being able to move the work forward. In thinking about innovations, the demand side, obviously listening to women, the gender dimensions and so on. We're just beginning to do some really very exciting work on male contraception. But an important part of that, again, going back to the social, is making sure that if these things come to market, that they will be taken up. You kind of talk about some of the implants and so on that women have, and the work in the male contraception involves similar sorts of implants. You kind of mentioned them, and men quickly cross their legs about, oh my God, there's absolutely no way you can give the equivalent of a device that women have been, IUDs that women have used for years. Anything similar that you talk about for men is totally unacceptable. we stick these things in under our skin, and it's so we do have to do that work as well in terms of trying to move the area forward. But again, we can't. It is an area that we can't divorce the social from the innovation. It absolutely has to happen. I think we have also neglected the innovations in systems, the health systems to support this area of work. And we have neglected a little bit our health workers and the workforce as well. So across the board, there's a lot of potential. So we don't just need to think about what happens within industry. We have to recognize that we've got a whole lot around us that we can use. And this is a time when we can learn from, what the pipeline looked like however many years ago. Now that the pipeline can include women, yay, that we use all of the tools that are that are possible. There's a lot of low tech. I think we're also neglecting the kind of the low tech, very simple low tech. And I brought with me. This is something that one of our research fellows just for a year, and it's just the regular tape. But on one side, you've got for abortion services a decision tool, like the normal wheel. Anybody who's worked in the maternal, that gives the right kind of, depending on the gestational age, what the right treatment is. And on the other side is the family planning, right family planning tools that includes the kind of the medical eligibility criteria to make sure that you're giving the right thing. For health workers, this is a simple, really useful thing, but I think we've got too caught up in the high-end technology, and there's a lot more that we can bring together for it. So yes, sexual and reproductive health, very
Yeah, thank you so much, Pascal. Normally, we would have had an AIDS activist and the CEO of the Mamas Club here with us, but unfortunately, because she's from Uganda, she didn't get a visa for this panel, so she could have probably added on to many of these instruments, and yet we need a bottom-up and top-down approach, and we've seen the Lancet reports, the BMJ reports, and also the McKinsey study on the 1 trillion opportunity. And I would like to come back to you, Oliver, on that opportunity, because women's health and women's health R&D that leads to a good pipeline and through strong products, we heard is $1 in $3. What are the most critical investments and policy shifts that are needed from your side? And also, do you hear women being more accurate when it comes to clinical trials in saying actually what the side effects are, which is potentially one of the reasons why they are not included so actively?
So what I can share with you, whether women are more accurate. So I'm a family father, I have a wife, I have 2 daughters, and I tell you, they are very precise. They measure everything I say and really look on whether that's happening or not. And I think we have a prime example here, what can be done. And for us, in order to commit to the sustainable development of society, it's really, really important that we collaborate with partners. Yeah, although we do this and try to do this in our trials, try to put in PIs, promote, talk about it, alone we are lost. So we really have to partner with institutions, with many, many stakeholders, with diverse background. And we are talking HCPs, we are talking patient organization, policymakers, everybody, because otherwise you cannot have a shift in the system. And I would like to point out 2 important partnerships to us. One is with the Global Heart Hub. That's also a non-profit organization. And here patients are provided a voice to talk about the cardiovascular diseases and what is happening there. And I think it's absolutely crucial to pay attention to this, since they really show you what can be done, what has to be changed, how can we improve care pathways, And it starts with, as we said, delayed diagnosis, due to wrong systems. You mentioned the example when you opened the speech today. So there's a lot of misunderstanding. There's a lot of non-realizing the gender differences. And I think, again, we must collaborate, we must promote this, we must raise awareness about this. Otherwise, it won't happen. And the basis for this must also be to really have more data. Data about sex-specific developments. And yes, you may be right by saying that women also have different symptoms and they showcase this differently to you. And yes, there may be also the fact that they report pain differently since they perceive pain differently. That is a matter of fact. But that also, I think, has to be included when it comes to study setups, to the trial design. And again, do this together with female practitioners, do this together with female patients represented by organization. Otherwise, you will run in the wrong direction and you won't address the root cause in these things. So I think policy also must be supportive, and I would like to mention the European Policy Center report, and I have to read it out, sorry for that. That's accelerating women's health, the urgent need for a dedicated women's health strategy at EU level. And I think this is really something very, very important. Here we have to team up with different stakeholders from research, from the civil society sector, and identify also the systemic gaps that we have in our systems and look into data. Do we have enough data? Are we allowed to share these data? How about data privacy? What you mentioned, for example, this must not be a hurdle, but we have to find a way how to better connect and how to better exchange and collaborate. And I think one of the important measures must be that also policy and politics is taking the leadership here. For example, with a report for the EU Women Health strategy by 2029. And this is something we must support, we must drive, and someone has to take the lead. And I think it's important that politics takes the lead. And yes, there are tons of global crises, but I promise you tomorrow will be the next crisis. And we still also have to work on some root causes in our systems and address these. Otherwise, we just build excuse by excuse by excuse and delay. And yesterday it was said by some colleague of mine, and the question was, how about sitting here again in 10 years? Yeah. Will we have the same discussions? Or did something change? And I'm a strong believer, it will only change if we do it now. And if we work on this, rather than finding excuses, why not to do this and that because of any crisis you will see in the world. This is my view on this. Thank you.
Thank you so much. I would actually like to, in the interest of time, open up the discussion and have a Q&A, if you like, and then we will go into a final round later with the panelists. But it is very important and interesting for all of us to hear also your views. We have a microphone going through the room, and I would very much like you to state who you are and which organization you're with, so that everybody knows who is speaking.
Hi, thanks a lot. My name is Daniela Fusco and I work for the Bernhard-Nocht Institute for Tropical Medicine here in Germany. And it's very, very interesting, the discussion. And I wanted to ask a question to all of you, because it's a lot of years that we talk about gender gaps, we talk about women, and as a woman, for sure, I want to bring forward this cause. But since a couple of years in my research group, we are trying to push the concept of gender a bit more wider, right? And you are talking about data, disparity, and actually we launched a couple of surveys in which we gave the possibility of talking about gender and the participants to tell us their gender, and both in Sub-Saharan Africa and here in Europe, it's very hard for people to disclose their gender. And especially when we talk about social determinants of health, we think that the gender as a wide aspect of the term is very critical. So I would like to hear your opinion about that.
Thank you so much. Maybe we can collect 2 or 3 questions.
Good morning.
Good morning.
It's
It's okay, it's on. Yes.
sorry. Good morning. My name is Vivian. I'm from Mozambique, and I'm also final year medical student, and also have an organization called Mutiana Voice. It works with female empowerment and development, especially in the reproductive area. So I would like to thank you for the excellent presentation. And I believe the innovation of the area of health and gender gap rightly reflects the challenges of promoting sexual and reproductive health in developing countries. In rural areas where information dissemination is limited, this problem is exacerbated by strong cultural beliefs. So tradition, taboos, and community norms that often fail to align with principles of equality and inclusion. My question is, how can we innovate in the context where cultural practices and myths continue to define what is acceptable and for the female body and access to health care? And also my other question is how the ethics relate to the marketing of intimate hygiene products, and also the marketing strategies employed often introduce women to prefer these products ever seeking medical care. How can we design the social marketing strategy that encourage the responsible use of those products and at the same time brings women closer to health services, considering the vaginal odor, and in addition to be medical issues, and also affect self-esteem, leading many to opt for quick and discreet solution, ignoring the criteria of effectiveness.
Okie doke. I will take up the cultural question if it's okay, and then you will find bilateral discussions for the rest of the questions, because otherwise it will be a little bit vast. Sorry, let's go to the other side. Maybe, I don't know who was first. I'm really sorry, I couldn't see many questions in the room. Just a lady over here.
Thank you. Is this on? Yes. Thank you. Good morning. My name is Malin Krok. I come from the Swedish International Development Cooperation Agency, SIDA. I think this discussion we have here today is very pertinent and very important, seeing what we talked about. I'm very happy that Pascal raised the issue that we should not, from the global north, stop pushing against the pushback. I think that with the Geneva Declaration and the fact that we see that the sexual reproductive health and rights for women and children, women and adolescents are so now opposed, we need to think about how we can use the health diplomacy that was raised earlier and find the strong allegiances to counter this very well-resourced anti-rights movements. So my question maybe to all of you, or to maybe Pascal and Frank specifically, is how do we do that? Because we know that the opposition is so strong and well organized. And so how do we do that in a smart way so we don't come across as being having some colonial language, and that we can still support the rights of women and girls to have and exercise their SRHR rights?
Okay, thanks so much. Sorry. My name is Okay.
So for just to make a comment, for a very long time in my country, we have grappled with issues around gender. But very recently, when we started involving men on issues of women, we are seeing some difference. Maybe it is a learning point in 4 areas. For a long time, we have grappled with what we are calling the circumcision of young girls. And for a long time, we take girls for trainings and women for trainings, and when they come back home, they find that old man who still squeeze them down and forcefully circumcise them. So when we train the fathers and the gatekeepers, we noticed a bit of a difference. And that also goes to early marriages. It even goes to breastfeeding. When we involve the men, we'll tell them, in my country, men like football. So we'll tell them, if you bring your wife, we'll take you somewhere, you watch football as you wait for the doctor. So then they support that process. So then I would like this panel to tell how are you doing to involve the men? And very recently, being the Breast Cancer Awareness Month, we are also looking for male champions because the person who gets to touch the breast first is the man. If they touch the breast and notice a lump, they will even be better to say, hey, we need to go for a checkup. But if they don't know that there is a lab to be looked at, they will not know. So it's very important that we, especially when you're talking about the developing countries, the lower middle income countries, where men are still the decision makers, it is very important that we involve them for successes of some of these gender disparities. Thank you.
Thanks so much. So let's have a break here let's have a break just for a second to give the panel the chance to answer a couple of those questions, and then I promise we will do more questions, but I just need to first have the panel commenting on all these important questions of gender, cultural issues, of course also men's health. Osteoporosis is another good example with men. And as we're discussing women's health today, I would just like to open the floor to all these three discussion questions. And maybe, Sarah, you would like to start.
Yes, thank you. All very thoughtful comments and questions. I'll start with describing one experience that I had as a researcher, and that was the work on the Lancet Commission on Peaceful Societies through investing in health equity and gender equality. Now, when you think of societies that are peaceful, you immediately, inherently think that, of course, people there are healthy, there's a high level of gender equality, right? And in societies that are not as peaceful, it's the opposite situation. But then we wanted to think, how do you invest in health and in gender equality in order for the societies to become or remain peaceful, right? And as Pascal described, you have different disciplines that literally speak different language when it comes to their thinking and the methodologies they employ in research. It's three completely different disciplines: peace, gender, and health. And first of all, we needed to find a language that works for all of us, right? But what we all agreed is that the data that we collect is very much, traditional, but still much needed data, which is, demographic data. We do not collect data on women's lived experiences. We do not collect data, also from health and gender, disciplines, on the context where women live. We speak about, different principles, the Universal Declaration of Human Rights, and so on and so forth. We don't know what are the mechanisms on the ground to support the women to be able to exercise those rights. Then we do not support the mechanisms to see whether they're able to exercise their individual agency, whether they have power, who has the privilege, who really makes these decisions. And then, as the lady said, they come home and they're succumbed to female genital mutilation. So we see all of this, statistics, but we do not see the nuances. And this is where we strongly advocated that, as also for innovation, if you really want things to happen on the ground, you really need to go to the ground and you really need to see what is going on. What we see right now is, as you explained, is very much male-centered or a white woman, very privileged populations. We speak about very high goals, but we leave so many people out. And they get very frustrated, and that is when we don't have peaceful societies, where we have, geopolitical shifts because people are unhappy. They feel that they're not part of the solution, they're not part of the equation, they're not part of the investment. So if you really want to make a change, start talking about, quantitative data, start talking with civil society organizations, people who are really living into communities, and allow also the communities to have a voice and to tell you, my husband likes to watch football. this is how he will come, and support me to have my reproductive or sexual health services and so on and so forth. So I think this is part of the solution. Just be where the decision making is and try to make a change there and be smart.
Thank you. As we had 3 questions, would anybody like to add on, for example, on the cultural question? Or
With your allowance, I would
Yes.
go in a little bit different direction,
Sure.
but at least I will try to answer one of the questions. And I think I will refer to an example that happened just a couple of months ago, and that was by the former Minister of Health. We all know Heiner Lauterbach in Germany, and he kicked off an initiative based on the let's say the fact that Germany starts lagging behind when it comes to the number of clinical trials, the number of patients being included, other European countries taking the lead, which is also okay. But he said, no, he's not happy with this. He wants to change something. And what he was referring to is make it for industry a little bit more easy to run clinical trials. And what is the biggest hurdle next to the ethical voting? Find the patients. Yeah? Finding the patients is the driver for the timing of a clinical trial that really drives the value of the trial, if you like to. So he proposed to be more open to disclose, of course, anonymous sick fund data in order to support pharmaceutical industry to run these trials more effectively, to run them more speedy. And I think it's a good idea that he had. And he also comes with an incentive. And what I learned in life, if you want to have a certain behavior of people, you have to either provide an incentive or come with no, and rules and regulations. I believe in this incentive thing. And this is something you may also use, for example, and say, look, we give you a different pricing when you can also show us that you include 50% female patients in your study, or look for different criteria. So that could be one thing that could really then work on the ground. I really like what you say. In order to be effective, at a certain moment in time, you have to leave the high level, go to the ground, and support initiatives that serve the ground. And then by the end of the day, it goes upwards again, and then you have the effect. So why not really, and sick funds, to my knowledge, we have sick funds in each and every country, for example. So why not strengthen collaboration and drive research there to make data more and better accessible, for example, supporting pharmaceutical development, industry research, and on the other hand side, have the big effect that we really take care that we close this gender gap, we start closing this gender gap, I should say, and have then incentives for companies for research, which is doing so. I think that may be a first step, an approach to really work for and cater for the gender gap, from my point of view. Thank you.
Thank you. Anybody like to add on any more points to the questions?
Yeah, I'd like to pick up the one from Seda. You practically raised the question, how can health diplomacy help in that context? The issue is very complex. Sexual reproduction, health and rights are the two, if you want, antagonists sometimes. Health is easier to sell and to market. Most countries will buy into that concept. It's the rights question where we get stuck. And this Geneva Convention, you meant the so-called Geneva Consensus Convention, became a corner piece of that pushback movement. We all know that. What we did, policy is aware of that. That's my first message. We are not just sitting idly by. There is a Nexus initiative under which 20 countries united in an effort to consolidate language in international fora to push back the pushback, which is what we referred to earlier. So it would be ignorant to believe, I believe the Geneva Consensus Declaration was signed by some 40 countries around that. That is a critical mass in international terms, and you can't just ignore it. It is a dangerous development because it erodes the very rights that we all subscribe to. that we want to uphold. And that's why our effort is a political one, to unite, on our part, the countries that are most willing to counter this development. There's over 20 countries who unite under this Nexus initiative to ensure that the right language is mainstreamed in international treaties, agreements, contracts, so on and so forth. So to counter, in political terms, the critical mass that those countries have built up, to weaken it in international fora, to ensure that the right ideas and concepts are introduced in, for instance, United Nations resolutions, agreement texts, and so on and so forth. So we are not closing our eyes to that. We have taken active action to counter that, and hopefully the number of countries under this Nexus initiative will continue to grow, because many more countries believe that this is a dangerous development and it should be stopped. On the cultural part, just an idea, an observation from previous years, also like you said earlier, I also served in Sudan, and I saw firsthand on the ground what happens in a conflict situation, like where all the fault lines sort of come together. It's never one conflict alone. One conflict breeds the next conflict, in my experience, and it's very hard to come out of that vicious cycle. All the more so if it's deeply rooted in traditional ways of thinking, of talking, of raising children, sometimes all under the guise of, oh, we are just upholding traditional family life. That is a very powerful argument in some regions of the world. Many people fall for it very quickly because they're not used to defending their rights. They sometimes don't even know their rights. And that's why we have a number of development projects. Again, I'm straying a little bit into the area of my colleagues' work, but I'm sure this is useful to mention here. There's, for instance, the Develop with a Triple P initiative, under which more than 100 development projects were launched, mostly in Latin America and African countries. And a great number of them focus on women's issues, women's rights, and they center on awareness building, on easier access to modern contraception. The figures are daunting, I think. Several 100 million today do not have access to modern contraception, which leads to unwanted pregnancies, which leads to unwanted abortions under unsafe circumstances. Microphone. Which leads to unsafe abortions, and so on and so forth. Again, it's a vicious cycle. And our projects are geared towards raising awareness, building understanding, but that needs to be rooted in the local acceptance. You can't do this coming from an outside country, carrying this to some revolutionary ideas into closely knit communities without being seen as interfering or meddling. This can very easily be exploited. So we need to step carefully there. And that's why we advocate local ownership of these projects. Once the people on the ground buy into the concept, once the leaders of the communities take it on, and that takes some convincing, once it is seen as their own endeavor, it has a better chance of surviving.
Thank you. So here's the deal. We have 15 minutes left. Because we're on a stream, we have to finish on time. I will leave 5 minutes to the very end, so that gives us 10 minutes for Q&A. We have plenty of questions in the room. I will let you comment on the 3 that were done already, and then we will go to Lisa. I don't know you. We will go from my right to my back. I saw your hand. And then I would ask you please to leave the question really short. But Pascal wants to first, I think, comment on what has been said. Leave the question short so that we have actually time to give you an answer. And if not, please grab any of us after the meeting. Go ahead, Pascal.
Okay, I'll try and be as quick as possible. There was a question on gender.
Yes.
I think we're good at measuring sex. We don't yet have the right measures for gender, but I think some of that, and this will be an overarching intervention, that we need to communicate better what it is we want. At the moment, administrative data is used. A lot of the data that we use, we collect as administrative data, and it's used for very specific purposes. If we want to extend it, then we have to communicate what it is we want it for in order to get the right measures. If the question relates very specifically to the range of identity issues, and as it moves, and I know it's controversial, but we are in WHO are just finishing off clinical guidelines for transgender and diverse populations. It's already been a bit of a headache, but it's evidence that is required that acknowledges different gender identities and the need to move towards it. So that will be coming up. Very quickly, there is a session after this on FGM, which I'm talking at, so if you're interested, please pop over. And a very, very quick question. So with a response to what's happening in the geopolitical space, I think what we found, certainly over the last couple of years, is that there is a very different discourse that is happening in the geopolitical space where these issues are used as political wedge issues. For some of the countries that are most against or are most vocal in the resistance, the anti-movement, we have some of the best relationships with their ministries of health. So while the counterparts in New York or in Geneva are having different discussions, the ministries of health are, there is some inconsistency happening, some dissonance happening there. And we need to be, I guess, in some ways it's about whether we just, pragmatically go on and get the job done for the women that we're working with, and how much we need to let these things divide our attention. It is a complex argument. It's a really important one. But I think, again, all I've heard is that we have to get our communication right, regardless of whether we're talking to communities at community level or with the diplomats in New York and Geneva. We have to speak the right language to get the outcome, the shared outcome that we all want.
Thanks so much. So second round of Q&A. Elisa, please go ahead.
I'm Lisa. I'm Ludi's colleague, heading our EU advocacy, and as an advocate, I would like to highlight that obviously there's so much expertise and awareness in this room, in research and innovation, at the academic level, at the multilateral level, technical level, in some parts of industry, in diplomacy, but I still see every week policies coming out that completely neglect what they could have done to improve or even just address women's health. EU life science strategy, EU pharma package, the word gender does not even appear. AI strategies launched last week, the word gender does not really appear, even, let alone sex considerations or women's health. So I would like to call up on all of you who have the awareness and who have the expertise to talk to your policymakers. And if you've been wondering what this QR code is about, it will lead you to a letter that we would like to send to the President of the European Commission tomorrow, because they are relaunching their women's rights roadmap on Thursday, and the highest standard of health is one of the rights that are prioritized in the women's rights roadmap. So we think there is momentum to highlight that we need an EU women's health strategy. And if you agree on that, and I think you also raised that we need to support this call for an EU women's health strategy that can maybe mandate that we can no longer ignore in policymaking women's health, then please go sign our letter by clicking on the QR code. And ideally, not just as individual, but maybe you're representing an organization that has some say, some influence, some knowledge. If you can give your organizational sign-on today, that would be amazing.
Thank you, Lisa.
I'm going to keep this very...
Yes, okay.
Can you hear me? I'm going to keep this very brief. My name is Shinabu Diallo. I am a program specialist and monitoring and evaluation specialist, formerly at the CDC in the U.S. I'm currently a global health researcher at the University of Alabama, Birmingham, where my research focuses on gender-based violence, early marriage, and its effects on women's mental health in West Africa. My question is very tight. Budgets are tight, suffocatingly tight. Implementation is difficult in low resource settings, or there's structural barriers that exist. We do discuss a lot of innovation in sexual and reproductive health, but practically, how can we sustainably scale and design interventions in this space to ensure that projects are still funded and prioritized?
Thank you so much. I think the gentleman, and then you. Okay.
Thank you for a great conversation. Tim Shan from Global Action on Men's Health, and also a researcher on sexual and reproductive health, particularly women's access to care. I think one of the paradoxes, using your term, Sarah, is patriarchy is bad for all of us. It's bad for women, but it's also bad for men. And we know a lot about men's bodies through research, but we're actually really bad at preventing men's ill health. And if we take sexual and reproductive health, I do extensive work with men around that area. Often men think it's mainly about women's health. They, in fact, object to conversations about it. They push back on it because they think this is mainly about women. When I talk to them about gender, they think, well, why are you talking to me about something that's only about women? And as we know, that the Lancet Commission on Gender and Global Health specifically said, when we talk about gender, we need to talk about everybody, not just women. So I think it's really a plea to how do we have a conversation that recognises the specific, unique and important needs that women have, as well as the specific and really important, unique needs that men have in relation to sexual and reproductive health, whether it's infertility, sexual dysfunction, whether it's reproductive cancers or beyond. And I think that's the way that we push back. That's the way we unite to challenge the pushback, which is led by men, led by patriarchal, white, global north men. That's how we all come together, is by saying gender is about all of us. But that requires us to move beyond an either-or conversation to a conversation that recognises that we're all in this together. Thank you.
Thanks so much. I think just the lady right next to her. Yes. Sorry, I'm going to collect all the questions now because we are a little bit tight on time, and then we will see. Just please go ahead.
Well, thank you very much. I'm Yara Bulwafa from an organization called Health Enabled. We focus on gender-intentional digital health, but I also do research on public-private partnerships and market-shaping incentives for women's health. And one of the things we see is that women's health, in the term women's health, for most of the partnerships, is focused on the global north. But when you start focusing on different countries, the conversations moves very fast towards sexual reproductive health and gender. And while, like Sarah said at the very beginning of the conversation, is that women's health is, like by virtue, is a problem of like systemic gender issues, but still women's health includes like autoimmune disease, includes like it includes like a vast variety of different conditions, much broader than sexual reproductive health. So my question for you is, how do we move the conversation in the global south beyond like the definition of sexual reproductive health and the focus on gender to a more broader focus on women's health that includes the different conditions, and also focusing on like market shaping approach and incentives to improve women's health within the global south? Thank you.
Thank you so much. Very good question. So do we have any, we had a question here? No? It's okay? Any further questions you would like to? No. So I would actually very much like to start with your question and give it to the panel, but not ignoring the other questions on sexual reproductive health and rights. And again, the appeal Lisa said and Oliver earlier on the European health on the European women's health strategy, of course, is a very important issue. And I just on a personal note, just before we stop and do the final round, I also want to say that I have been asking myself the same question, because you are, obviously we are women. Women have diseases, disease areas, normal disease areas. Then you are a person who has a sexual reproductive health, and then of course you have very women-specific diseases that only affect women. So, and then you have a big portion of that is affecting men as well. So, so it's a very interesting discussion because we see how it's sometimes unfocused, and that's what it's a personal opinion. Normally, the moderator shouldn't have that so much, but I really want to, give that into the round of discussion because it's more than cardiology, of course, also probably in Daiichi Sankyo, but it's also more than sexual and reproductive health and rights. So I think that gives us a good base for short commenting maybe, and then also the implementation into the real life. That is what I would ask you to do with one sentence or two. Maybe in that very round, where do you want to be in 5 years? What's the one thing that we need to change now quickly? So with not much further ado, and I see the sign of 5 minutes, I will hand over, I think first to Oliver, because you're on my left-hand side.
Okay. Happy to do so and to support you. So maybe with to the comment of regulations. I need a mic. Sorry. So I would like to start with the regulation point that has been mentioned in the beginning of this question round, and I think we also have to reflect here that currently the healthcare system is really shadowed with, for example, the MFN politics that we see here. On the other hand side, we are just still recovering from the effect of COVID, where the important need was bring research and production back to Europe, for example, in order to have stable supply chain. That was the biggest need there. And I think all these things, they go together. So we really have to reflect this, and but at the same time not forget about driving women's health and also implement it accordingly. So as the World Health Summit explores how to close the gender gap, we advocate for using this momentum. We create more and more people, and if I compare to last year, I think we almost doubled, at least I have the feeling, it looks like. So it's growing, we are creating momentum, and we have to implement this into national heart health plans, and of course do the same at an EU level. So we call for an EU cardiovascular health plan that addresses the gender disparity. And of course, as I said in the beginning, we cannot do this alone, so we have to ally with many different stakeholders. And I'm not saying this just as a representative of pharmaceutical industry, but also as a family father, having 3 female family members at home, and I wish they have the best health that they can get. Thank you very much.
Thank you, Oliver. And Pascal, we're so looking forward to seeing you in the next panel. But maybe you would want to also comment on what we heard in the last round and give an inspirational statement.
Okay, so just very quickly, in 2009, WHO released a report called Women and Health. And in some ways, that has been the way that it's been conceptualized. Structurally, a lot of that work then moved into the Department of Sexual and Reproductive Health, but it's too reductionist. I totally agree that it's too reductionist, and even within the area of sexual and reproductive health, we do a lot more in the reproductive than we do in the sexual. So we've changed the narrative a bit to ensuring that we're working on women's health as it relates to being productive as well as reproductive. So that it is across the spectrum of women's health. Now, the reality is, again, that we cannot divorce women from being sexual beings. And whether it's osteoporosis, or we do have to make sure that the hormones that make us women are a critical part of what it is. So it's one of those issues where I think, again, in terms of communication, we make it very clear that it is, when we talk about women's health, we're not talking about sexual and reproductive health. So just to clear that. What I would like to see in the next 5 years, obviously I've talked about some of the products that we're hoping to release through WHO, through the guidelines community and so on, my wish is that we stop addressing women's health as fragility. Menstruation, pregnancy, menopause, all of these are not pathologies. They're markers of life, resilience, and biological sophistication. And so the challenge is about us getting to the point of recognizing that and making sure that we get the science that will back it.
Thank you so much. So the cameras will go off in 1 minute, so I would like Sarah or Frank so please, between the two of you, 30 seconds left.
Okay, I'll try to be very brief. On those previous questions, I'm bundling them up a little bit. First, how do we enlarge the spectrum of women's issues in health? For instance, by taking a principled approach in international fora, and that means women's health issues are fundamental human rights. You can divide them obviously in SRHR rights and other rights, but they are human rights as such. And this is what the federal government is doing. We're not compromising on that language. I tried to indicate that earlier, and that broadens the spectrum automatically to include other forms. The gender aspect, thank you for raising that. Also, maybe that fell by the wayside a little bit. When we talked about SRHR, gender is firmly included. There are two sides of the same medal. And especially over the past 5 years, I think Germany went a long way internationally to really was seen as a torchbearer and not always appreciated in other parts of the world because we had the guts to stand up and do just that, what you were saying. So gender is a firm part, if you want, the other twin brother of that. 30 seconds.
Okay,
Sorry, I'm out of time.
Yes, to build on what Oliver said, COVID-19 really showed us that, the things that we innovate are not really neutral. They really represent our preparedness and our priorities. Right now, the priority needs to be gender equality. We need to prove that it is not just something that we put as a tick box, but it has to be proven to be essential.
Thanks so much, Sarah. Like this, we can all say thank you on time. Thank you to this wonderful panel. Thank you to all of you in the audience. We made it on time, I think. Please go ahead and have bilateral discussions, as many as you like. If you need anything, let us know. Use the app, use the QR code. Have a great day.